Thank you for choosing Axxess On Demand. Axxess believes in continuing education, and we create content to empower you to learn and grow anytime, anywhere. Let's get started.
Good afternoon. Thank you for joining us for a live webinar to help you prepare for the upcoming changes associated with the implementation of the patient-driven groupings model. Today, we will hear from two industry leaders who will discuss what home health organizations need to know now to prepare for PDGM. My name is Molly Casey. I'm with the marketing team for Axxess. Before we get started, let me share a bit about our presenters and the organizations they represent. Bill Dombey is an industry expert with many years of experience in legal, legislative, and regulatory advocacy on behalf of patients and providers of home health and hospice care. He serves as the president of the National Association for Home Care and Hospice, the largest and most respected professional association representing the interests of chronically ill, disabled, and dying Americans of all ages, and the caregivers who provide them with in-home health and hospice services. In addition, Mr. Dombey serves as the director of the Center for Healthcare Law and as the executive director of the Home Care and Hospice Financial Managers Association. Joining Bill today is Ms. Deborah Hoyt, a highly regarded healthcare public affairs professional with many years of experience in grassroots advocacy, corporate communications, media relations, and government affairs on the state and national level. She has served in executive roles for a Fortune 100 health insurer, a state home care association, and a managed care organization. Deborah brings a keen understanding of federal healthcare issues in her role as Senior Vice President of Public Policy for Axxess. Axxess is a leading home healthcare technology company that offers a complete suite of technology solutions to empower home health, home care, and hospice providers to grow their business while making lives better. A few quick housekeeping items for our presentation today. Everyone's phones are muted. However, you may submit questions throughout the presentation, and we will follow up with you afterwards. Following this webinar, we will provide everyone with a link to the slides and post a video recording of the webinar on our website, axxess.com. Deborah, I'd like to hand it over to you and Bill.
Thank you, Molly, and good afternoon, everybody. We're so glad that you've joined us. Axxess, as a technology solution partner, is working very closely with our National Association for Home Care and Hospice, along with the state associations, to make sure that our home health agencies across the nation are ready for the patient-driven groupings model. As you know, NAC has rolled out a full webinar and live in-person roadshow throughout 2019, and Axxess has done similar around the country. We want to be here for you, and we've reached out to Bill Dombey and NAC and said, could we do an end-of-the-year recap on the final rule and what PDGM is going to mean? And Bill and NAC have been very helpful partners in terms of being accessible to us and also to you to make sure that you're ready for this big change. So I'm going to turn this over to Bill. He's going to present a very detailed slide presentation on all of the aspects that you need to be ready for, and then we'll do a couple of Q&A afterwards. So Bill, I'll turn it over to you. Thank you.
Well, thank you, Deb, and thank you, Axxess, for the opportunity to spend some time providing an end-of-the-year explanation of the 2020 rule on the patient-driven groupings model. The program is going to be a primer of sorts, but getting back to the basics is always important, particularly since this new rule, this new payment model, is really a transformational change for home health agencies doing work for Medicare patients. It is the biggest change in the payment model in the last 20 years. And so the more and more familiarity you have with it, the more likely you will be successful about it. So let's get started with this. And we start with a link to the Federal Register and the actual rule that appeared on everybody's second favorite holiday, that being Halloween. On Halloween Eve, Medicare hit us with a little trick and treat itself with the payment model provided in great detail. So if you're looking for something else to do after the session's over with, click that link on and you can get started reading nearly 400 pages describing this new payment model. A couple of basics to understand from the rule, is the PDGM actually only applies to episodes that begin January 1st, 2020 and later. That the existing payment system has been updated, and that doesn't affect any episode of care 31st or earlier. The longest that the existing model can go is February 28th, the 60th day after a December 31st admission. So that means that home health agencies are likely to need to run dual systems over the first 2 months of the new payment model, and then full-blown into PDGMs coming into March. The per visit rates for LUPA claims have been increased by an inflation factor of 1.5 points, and those LUPA payment rates are going to be the same for both models. But as you all have experienced over the years, episodic payment rates and the full amount paid for a unit of service under PDGM will be more likely to be the business model for you, as LUPAs are a vast majority of the episodes of care. Now, in order to understand PDGM, I want to take you back a little bit in history, and that's to the 2019 rulemaking. In 2019, Medicare laid out the architecture, the design, the framework for PDGM, and it sticks with that framework in the 2020 rule. It's pretty much just tweaked a little bit here and there, and as such, the payment rule sets out payment rates. Also, an important area that we'll talk some more about in depth, and that is a behavioral adjustment. They did revise the adjustment from the proposed rule, even though they used the same framework, the same concepts that they had outlined originally in 2019. The new payment model does continue an outlier element to it for those high-cost patients, and we'll give you a bit of information about that. It's very comparable to the outlier standards that you're familiar with just a minor adjustments in that. As with the existing payment model, payment rates are updated by a wage index, and this is oftentimes a bit of a hidden issue for home health agencies. The vast majority of agencies, the wage index doesn't change where they are much from one year to the next, but invariably there are a dozen or 24 geographic areas where there may be a big swing. So that if you were looking at your 2019 setup with the wage index, it really behooves you to take a look at what's happening in 2020. It could be putting a smile on your face because you're on the upside of it, or it could put a frown because you've not seen just a tiny little change from one year to the next. You might have seen a significant change. And if you were planning all of your impact analysis around the case mix weights that appeared in the 2019 rule or the proposed 2020 rule, got to take another look at it because they've recalibrated all 432 case mix weights for the PDGM system. There are RAP changes, and you could hear the tone change in my voice there. The RAP changes are not going to put that smile on your face, definitely creating some cash flow concerns, and we'll talk further about that. And then CMS did take some steps around its proposed notice of admission requirement. The notice of admission is intended to put the patient into the Medicare system so that other providers and Medicare contractors know that home health services have begun. And we'll give you the detail on that. The notice of admission is slightly delayed because of some of the RAF changes that they came out with. So we're going to take you even further back in history because this is necessary to understand where we are today. In early 2018, Congress passed the Bipartisan Budget Act of 2018, otherwise known as BBA for short. And the home health community was successful in getting our congressional allies to be able to enact some changes to CMS's plan in terms of revising the payment model. If you go into 2017, many of you may remember the home health groupings model, HHGM. It was a disastrous proposal for home health agencies, and through the advocacy that happened nationwide, CMS stepped back and away from HHGM, but that was with the understanding that they were going to do payment reform of some fashion in the not too distant future. Congress then set the stage for that reform with the Bipartisan Budget Act of 2018, starting with a mandate that the model reform begin no earlier than 2020. And that's what brings us to the PDGM model starting January 1st in just a few weeks' time. Big change that came through the legislative action, demonstrating the value of advocacy and your engagement in that advocacy as consumers of Medicare services. As a provider of Medicare, you're essentially a consumer from the Medicare perspective. And that was a switch out of the HHGM proposal for an across-the-board 4.3% cut in payment rates that the money was just going to disappear into the stratosphere. Home health agencies were not going to get it in any form or fashion. And that was worth about $17 billion a year, in 10 years for cuts to the home health community. Congress stepped in and said any new payment model has to be budget neutral. Now, budget neutral does not mean each and every home health agency has a revenue neutral outcome. This is in the aggregate. This is the $18 billion of spending in the Medicare program and whatever the projection is for the future, that the design of the model had and the payment rates set accordingly had to try to achieve budget neutrality, spending no money more nor any money less than if we continued the home health prospective payment system model currently in place. Now, one of the other things that came out in 2017, and in that year in HHGM, it was a hidden aspect to the CMS proposal, and that was a behavioral adjustment. And again, that's going to be a big part of my walkthrough on PDGM, but it was in 2017. Behavioral adjustments have been in every sector for decades now in the Medicare program because providers of services change behavior as payment models change. Home health changed behavior when the prospective payment system came in. Home health agencies changed behavior in the late 90s when the interim payment system came in. Hospitals, doctors, nursing homes, all have had behavioral adjustments. But Congress came forward and said, we're going to put some guardrails, do a little protection for you on any imposed behavioral adjustments. Still giving CMS the power, though, to make such adjustments. The law required stakeholder involvement, and CMS followed through on that obligation. They held a technical expert panel. Obviously, they offered a regulation for public notice and comment, too. Two elements, though, of the framework of of the home health grouping model, HHGM, were then continued to PDGM by way of the congressional mandate. Neither one came as a surprise when Congress legislated this. There was a lot of activity, a lot of discussion. We all were involved as stakeholders. And those two elements were, number one, prohibiting the use of the therapy volume as a payment adjustment. As you know, in the current model, the number of therapy visits greatly change what the level of payment may be. And that was the case since the beginning of PPS in October 2000. Unfortunately, though, it was viewed as an instigator of overutilization of therapy, an incentive to get more money by delivering more services. It pretty much didn't fit as well into a prospective payment system because that's supposed to be based on patient characteristics, not the level of resources actually used. So there were concerns about it from a program integrity perspective, concerns around it regarding the overall utilization of services. On the other side of the coin, it did initiate the delivery of rehabilitative and maintenance therapy services to people all across the country who in the past may not have had access to them, yet money made providers change behavior there, but in that case, in most instances, in a positive way. Still on balance, Congress agreed with Medicare that they had to drop out the therapy volume threshold as a payment determinant. We at the National Association for Home Care were in agreement with them in doing so. And actually, our agreement went back to 1999 when it was first proposed. We didn't think it was a good idea to begin with. The second piece that came in the Bipartisan Budget Act was a shift from a 60-day payment unit to a 30-day payment unit. Quick little background on that. The 30-day payment unit was embraced by Congress because it believed, that the members in Congress believed, that home health patients who are on service for 30 days or less were bringing double the level of reimbursement to the agency than the agency deserved when they were being paid on a 60-day payment unit. That wasn't accurate, but we were not able to break through them to get them to understand it. Congress doesn't get as deep a dive into Medicare home health payment models as you all will. So here's the basics again, just to repeat: 30-day payment unit, the therapy utilization domain dropped. The 153 case mix categories expands to 432, and the elements that are measured that matter in terms of reimbursement rate that are tied into the scoring of the individual is: when did the episode occur? Was it the first episode of service, and I mean the first 30-day period, which would classify it as early, and that brings higher reimbursement than the second category, that's late. There's only one early and everything else is laid after that. A significant factor in determining reimbursement is whether the patient's admission source was from a hospital or skilled nursing facility, or did the patient come from their own home, from within the community into home health services. A community-oriented admission of the same type of patient, what I mean by that, same clinical elements for the patient, same functional capabilities, same comorbidities, the community-based referrals will bring lower reimbursement because the data showed that those patients, for whatever the reason, use fewer resources. An adjustment around LUPA, dropping the 4-visit threshold that was applied to all 60-day episodes, and instead establishing a range of 2 to 6 visits. And here you want to footnote this: 2 to 6 is not the equivalent of 4 in terms of when it starts. With the current LUPA, you get paid per visit up through visit 4. In the new standard, when you have a LUPA threshold of 2, that's when you'll begin receiving the full 30-day payment. When you have a threshold of 3, 4, 5, or 6, those are the points when you get the full 30-day unit. CMS has on its website a whole sheet explaining what the LUPA threshold is for each of the 432 groups. As with the current model, it is a bundled services payment, but what Medicare did for this new model is there's no longer a non-routine supply add-on. This is supplies and services are bundled together. And as I mentioned earlier, you need to check all the case mix weights for the final 2020 rule because they're different than 2018 and the proposed rule as well. Where does that all end up? A 30-day payment unit base of $1,864.03. That will be adjusted by the case mix weight of each of the 432 case mix categories, as well as the wage index. CMS estimates that is 11% higher than the average cost of a 30-day period of care. And they also estimate that if there was not an inflation update, that the payment amount would have been at $1,824.99. So Congress, when they gave a 1.5-point inflation update in the Bipartisan Budget Act, added that nearly $40 difference in reimbursement. What I don't have on the slide, but to give you some context, if we had the home health grouping model, HHGM, that 1864 would be in the low 1600s instead. CMS had proposed at a 1 year earlier start that it would be $1,607. I'll credit once again the advocacy of those listening in, the advocacy of the state associations, and those with a national voice, along with our partners in Congress to get that kind of a change about there. But 1864 is still lower than what would be budget neutral, and that's because of the behavioral adjustment. This slide simply shows you what the per visit payment rates are. The behavioral adjustment does not affect those. I'll tell you a bit in a moment on the behavioral adjustment. Just want to touch a couple of other areas. Outlier, continuing the 2019 formula, which uses a 15-minute unit approach, and the FDL, which is the fixed dollar loss ratio. FDL sets up at what point in time does the outlier payment begin, and fixed dollar loss means that you have to reach a point in your costs, and these are imputed costs, not actual costs, before outlier starts, and they increase the FDL from 0.51 to 0.56. That will have a minor decrease in the volume of outlier claims that are out there. Outlier generally doesn't cover your cost. It is cuts a bit into the losses that you get there, mitigating it, but you'll see a fewer volume of outlier claims. Probably not a game changer for anyone financially either way. The behavioral adjustment, which I've referenced a number of times now, is really the main focal point for our advocacy, the main focal point for many of you in looking at, how's this going to work, and also the focal point for a lot of companies who are saying, well, what can I anticipate internally as to things that might change in the organization and the behavior of the staff? The final rule maintains the proposals framework, which is to say there are going to be changes in the clinical grouping, the comorbidity reporting, and the number of LUPAs that the Medicare program expects to experience. If all things were even, there would be no change, but they believe the behavior change would be there. Let's take each of these one at a time. The clinical group change is where CMS has assumed that there will be many circumstances where the home health agency shifts the secondary diagnosis to the primary diagnosis. And primary diagnosis is the diagnosis that you're treating in home health, not the discharge diagnosis from a hospital, but really the treating diagnosis. And it very often the treating diagnosis is different than, say, the hospital discharge diagnosis. And CMS says that they assume that home health agencies will shift from secondary to primary to a point where it would increase spending otherwise by 6.4%. That's not saying this is an abuse. It could include abuse, but primarily they're saying it would include circumstances where the agency now pays more attention to it. This is a higher degree of accuracy regarding the listing of the diagnosis, because under the current model, diagnosis doesn't matter much at all relative to reimbursement, and now it becomes a key factor, and so agencies will pay attention to it. So they had this formula where they looked at primary to secondary, said about a third of the time they will be moving up from that, over time, increasing then expenditures. So their goal with the behavioral adjustment is to then offset that behavioral change with a rate reduction. Comorbidities are not relevant to today's model, and agencies are now expected to include comorbidity, but a minor impact it has on reimbursement, and on a behavioral adjustment, CMS credited in a minor way with a 0.25%. Finally, LUPA, when Medicare's prospective payment system started in 2000, the number of episodes that would become LUPA reimbursed was about 15%. Over time, that dropped to about 8%. And CMS, in its own analysis, says that's because of behavioral change. Instead of getting 4 visits, the home health needs to get 5. The difference was between getting $600 versus getting $25 or $300 or $3,000 is a big incentive to add that visit. So CMS is projecting that home health agencies will add visits to get that full reimbursement instead. When you put it all together, that adds up to just under 8.4%, 8.389, which is an increase over the proposal of 8.01. Now, if you're reading that Federal Register that I gave you the link to earlier, what you should do is read the executive summary, because it gets to the conclusion faster than if you read everything else. The conclusion being that CMS ultimately reduced the adjustment from that 8.4 level to 4.36%. It took a lot of advocacy to get there. We and others met specifically with Seema Verma, the administrator of the Centers for Medicare and Medicaid Services, and her staff to try to explain. We had serious concerns about this adjustment, its accuracy, and the like. And while they didn't change their calculation, they changed the timing of the impact. And they made a sensible choice here. The 8.389 would have required that 100% of home health agencies made 100% of the assumed changes on day one. And just even saying that, you could hear how ridiculous a concept that is. So rather than applying it from day one in full bore, CMS said, at most, it'll be phased in, so they reduced it down to the 4.36%, which represents, in math, ultimately a little complex to get you there, about 50% of the behavior changes that they affected. That had a value to home health agencies of over $725 million of now guaranteed revenue that they will get. We still expect behavioral change. CMS still expects behavioral change, but we're not starting in as big a hole. That's what gets us to the 1864 instead of a lower number. A couple of final things to talk about in terms of the system itself. This next item, the RAP phase out, is probably my number one concern starting in early January. The RAP is the request for anticipated payment. In today's model, home health agencies for the first episode get 60% of what they are expected to be paid at the end of the episode in order to handle the costs that are incurred during that 60-day period, and then the waiting time to get the reimbursement and so on, cash flow needs. And you get 50% for second and later episodes. In this, starting in 2020, any new home health agency, that being defined as starting in Medicare January 1st, 2019 or later, will not get any RAP at all. So you're on your own to cover the cost of care for that period of time, that 30-day period, plus the time it takes to pull your claim together, plus the time Medicare takes to pay your claim, that includes even a 14-day waiting period, a floor they call it. Existing agencies will continue to get RAP just in 2020, but it won't be at 60%, it'll be at 20%. The reasoning that CMS has in getting rid of it is twofold. The driver, more than anything else, is a program integrity one. CMS had found, and we believe only a few cases probably like this, where there was fraud around the RAPs, where a company would bill RAPs only and then run for some country where you can't get extradited back to the US, take the RAP money and never serve a patient at all. Obviously, it's overkill when it's going to affect every home health agency. The second reason why is because of the shift to the 30-day payment unit. CMS's view, which we don't agree with, is that the cash flow concerns for the home health agencies are significantly lessened. We really believe, though, cash flow is going to be issue number one in the early stages of RAP, as it takes time to get used to a 30-day kind of billing cycle, but it also takes time just to get the claim in and get paid. You still may be looking at the earliest 45, 50, maybe 60 days after the start of care before you're paid, and payroll doesn't get suspended in the meantime. So that means agencies in 2020 will have to fill the gap from a cash flow perspective with capital, with lines of credit or some other way, and even taking further steps, because starting in 2021, nobody gets a RAP. And so obviously creating a whole new business responsibility for the agencies. The RAP submissions through 2021, are going to be used, though, as a substitute for the notice of admission. You will be required to submit a RAP, even if you're a new home health agency. It will be a no-pay RAP, because this is what gets the patient's admission into home health and care in home health into the Medicare data system, so that outpatient therapy, for example, can go into the common working file and know that they can't deliver care and get Medicare reimbursed because the patient's an active home health patient. Medicare will be instituting a penalty for late RAP submissions starting in 2021, where the penalty begins if you don't submit a RAP within 5 days of the start of that 30-day period. You will lose 1/30th of your payment for every day that it's late, but that also includes the 5 days in which you have that window of opportunity. So if you submit it on day 7, you're going to get a 6-day penalty. 6/30th is a lot of the reimbursement rate for that. So this is intended to push home health agencies to accelerate getting all the paperwork done and getting into the system. The notice of admission serves a similar purpose. This slide just indicates it begins in 2022 with the same kinds of aspects of getting notice regarding the status of a patient. The next 2 slides are really there as a handy guide in a summary form, comparing the proposed rule to the final rule and explaining what it's all about. So I've walked everybody through all that stuff already. That's just there for your convenience. There's continued advocacy around PDGM. Legislation is pending that would roll back the rule with the behavioral adjustment, eliminating that 4.36% base rate cut. However, since the final rule came out, there has been a lot of consideration of next steps by Congress, and we are basically of the position now where Congress is not going to move forward with this legislation to roll back the rules. So you can anticipate everything I just told you about 2020 will be in place, including that payment rate. We are still in discussions with our congressional allies about trying to provide some protections for 2021 on any behavioral adjustments that they may be making, a combination of being more transparent about it, but also avoiding the use of assumptions wherever possible, instead basing it upon real data. So stay tuned on the advocacy side of it. To engage in the advocacy side, you see the second bullet from the bottom there. That's a link to an advocacy page on the NAC website where you can send messages to Congress to support continued efforts to protect home health agencies from PDGM related matters. So Deb,
okay,
I'm a little out of breath, so I'm going to turn it back to you, and we can have a discussion that might be some helpful to the audience.
Sounds great, Bill. Thank you. You know, for those that are listening, I think only Bill Dombey could give a summary like this, because this is not just telling you and informing you of the changes that you should expect as a home health provider agency, but it's giving you the background and the context as to why CMS and Congress have been moving in this direction. As we all know, home-based care is the most appropriate place for people to be as we're moving forward with our aging population here. And it's not going unnoticed by CMS and Congress that more and more people are receiving home-based care. So they're taking a look not only at our reimbursement under Medicare, but also for the skilled nursing facilities. And they just went through their own PDGM, started back in October. So there's a couple of months of experience that we're starting to hear and see some data on in terms of how they've been doing for the first 3 months. But I think really what we're looking at here is, you know, a fundamental change as to how home health agencies have to look at not just their billing and operations, but really take a look at everything from intake and how their clinical folks are really approaching the patient. It's really looking at value-based, home-based care. And I think the intent is probably right in terms of, you know, not looking to drive excessive therapy when it's really not needed. Let's take a real good hard look at how we schedule our clinicians and our home health aides to really meet the needs of the patient. So a couple of, you know, those are just some of the takeaways and things that I kind of heard from you, Bill. One of the things that, you know, you've been advocating as NAC and also Axxess when we're out in the field, you know, on our, you know, various seminars and roadshow out in different cities, is that home health agencies can't do this alone. This is extremely complex. We really want you to rely on your technology. Hopefully you have a good technology solution provider that's able to be PDGM compliant for you and with you and hold your hand as you're moving into this on January 1. I know that Axxess is compliant when it comes to PDGM, and we'll walk our clients through making sure they're coding appropriately. We'll allow you to bill inappropriately to make sure that you're compliant. Other vendors too are doing the same thing to make sure that the industry is going to remain, you know, strong and viable as we move into 2020 and beyond. I think that's really critical. So make sure you talk to your technology solution partner and make sure that, you know, you're using the full capacity of the software to make sure that you're going to be able to be functioning and getting your billing out on time so that you can get revenue in and pay your staff on time. Bill mentioned cash flow issues. I think the first couple of months as we see the RAP percentage decline down to 20%, it's going to be really challenging for agencies to survive. So many of you have already been having conversations internally with your staff to make sure that they all know their responsibility, from the people that answer the phone and intake all the way through to those delivering care. You know, so Bill and I were chatting a little bit before the call regarding readiness. You know, we're just 2 weeks out, Bill, before January 1. I know that a lot of the consultants to the industry have been working with a lot of home health agencies, taking a look at their data and maybe crunching some numbers for them. We've heard kind of things all over the board in terms of how we're going to look at the industry. What are your thoughts on this?
You know, it's never inappropriate to check your readiness when you've got such a transformation coming on. And we think there are some readiness checks that you could look at in all sectors of operations, clinical, financial, your business analytics, and as you mentioned, your technology partners, both internal on the technology side, but externally with respect to partners like Axxess, where many tools are there. But you know, if anything, I would make an assumption that the technology company may be more ready than the home health agency because they've been working on it for such a long time. And even looking at the readiness of third-party stakeholders, you know, cash is extremely important in this, and a backup plan to deal with this absolutely essential. Not only are we dealing with the loss of the full RAP payment, dropping it down to 20%, but we're going to see a high risk that CMS may repeat its own behavior as they did with PDPM, the nursing home side, and CMS was not ready to process the claims accurately and on a timely basis. So it may be that they don't get the 20%. But the key readiness factor is getting your team together within the organization overall. If you didn't have clinical people in sync with financial people and vice versa before, you need them to be in sync now. Now, we've always been advocates for having a clinician control what clinical services are rendered, but the clinicians need to know what the outcome ultimately is for the operation there. And what the clinicians need to do more than anything else, in terms of readiness, is be ready to go on the issue of the primary diagnosis. And you can guarantee that the physicians are going to send information, which has to mean going back to the doctor in order to get the right ICD-10 code for this. So the clinicians focusing in around on that. The other readiness aspect that we are seeing being pulled together all across the country is more of an interdisciplinary team kind of care planning. And pulling away from letting a discipline on its own, say therapy or otherwise, determine how many visits are necessary, coordinate all of it because there's that interaction between one visit or another. And on the clinical practice side, as much as they've stepped away from therapy as a payment determinant, it is still a patient outcome determinant, and people should not react in a knee-jerk fashion to withdraw therapy services to get to a better bottom line consequence, because that may be of short-term value and long-term harm when patient outcomes deteriorate. Placing that home health agency, going from a 5 or 4-star status to a 1 or 2-star status, and they will see much greater financial consequences than just the PDGM rates on that. So readiness is there, and getting the team together, getting the culture all focused on PDGM. We believe that everybody can make it work within PDGM if they put the effort into it. This is not a disastrous change, but it's one that requires some coping.
Mm-hmm. I really like your interdisciplinary team concept, and I think many home health agencies have been preparing since last summer or even last spring, getting their teams together and actually educating the clinicians in terms of how they code is really going to determine, their payment. And under this new model, that's critical. I think in past delivery systems, the clinician really didn't have to worry about that. But this is something that I think educating the entire team is very critical. So thank you for that. You also mentioned not just the interdisciplinary team, but also some of our partners, some of our referral partners like physicians and other referral partners. I know NAC was rolling out its physician toolkit yesterday. Do you want to mention something about that?
When you look at third-party stakeholders, physicians and discharge planners, are among the two most important here, but particularly the physicians, whether they be the community physician or the inpatient physician who starts the ball rolling in terms of that diagnosis. The other aspect of physicians that really plays a big part, in the stability of the transition from current model to PDGM is the whole aspect of getting the documentation in hand on time. So we put together a toolkit that is made up of an e-brochure that could be printed out. It's a trifold kind of a thing that really focuses in on what physicians should expect to see change from their end with PDGM. And a lot of it has to do with just the timing. With a 30-day payment unit, while the care plan will remain every 60 days and the OASIS patient assessment will remain every 60 days, the home health agency is going to be coming earlier to the physician to get the signed certification, get the signed plan of care and the signed changed orders in order to do the billing. So the physician needs to be anticipating that there's going to be a few earlier knocks on the door. And there may be knocks on the door also relative to the diagnosis. Some of the diagnoses that are considered unacceptable, and we outline those in the toolkit as to what their generalized weakness is not going to be a sufficient diagnosis for anything, and it'd have to be more precise, and particularly focused on the primary reason why the patient is receiving home health services. So the toolkit includes the brochure. It includes a much more detailed explanation to physician, but also a videotape starring our own Mary Carr walking people through. It's about a 7-minute video. Some people prefer reading, some people prefer watching, some people like to do both, so we put together all of that. And that toolkit's available to everybody just on the NAC website, nac.org. You can't miss it if you open up our website. It'll hit you square in your eyes. It's right in the center of that homepage.
Thanks, Bill. I think that's going to be a terrific resource, and we'll make sure we add that link to the end of this webinar when we send out the slides, so everybody will have it available to them here too. And I think probably lastly, NAC has done an extraordinary job in educating the industry. We're so invested in making sure that agencies are going to be successful in this transition and try to do the best they can to be educated. So we're kind of coming to year end now. what are NAC's plans to kind of continue education and advocacy through 2020 as we see implementation of PDGM rollout?
Yeah, sure. We've got a pretty robust plan that, probably the last week or possibly the third week, we haven't scheduled it yet, will be our first webinar/chat. It will be a combination of providing information, particularly on a subject might be cash flow being the focus, but a good portion of the session, the webinar, will be a two-way chat between ourselves and the audience. We'll be having our experts from the Home Health Financial Management Association part of that whole process. It's repeating a model that we used with pre-claim review and the review choice demonstration program, where we're able to get real-time information regarding issues and concerns that are coming about from the field, from the home health agencies themselves. It allows us to get that real-time information to CMS quicker, so that if corrective action is necessary, it can be done, but it also puts us in a position of spotting areas where we could fill the gap with further education or other ways providing some support. We'll do a series of probably 6 or 7 of those webinars between the end of January and the middle of March. And then at the end of March and the first week and a half of April, we're going to do a road show, a blast tour, all within a very short period of time, a one-day, full-day seminar, as we did in 2019 with the rollout of PDGM. But this one-day seminar will, in 12 different locations, will be based upon what we've learned to date at that point. It's not just again, a primer about PDGM. We're way past that. We're past theory. We're past, possibilities. We're in real life at that stage. And so our experts from HHFMA and NAC, consultants as well, will be banding together as teams to talk about issues related to operations, financial, clinical, business analytics, technology, and as such. And we're working it out with our partners in the technology world to help us gather some real-time data too in the aggregate, so we can see, are there changes in behavior that are happening on case mix weights, on LUPA volume, all those kinds of things that are important that will help us both educate but also prepare for the next round of advocacy, because Medicare will be in April coming up internally with its 2021 payment rule development already that we'll see in a proposed form probably in July. So we culminate our education for the first half of the year at our financial management conference, which will be in Las Vegas in July. Yes, it'll be hot in July in Las Vegas, but no one's going outside. They're going to be inside learning everything they need to know about financial management and home care and hospice. But we'll have a whole series of PDGM related programs and a pre-conference as well that goes with it to get a little more in depth on it. So we do believe, and our experience tells us this, that advanced preparation and continued awareness activities, education activities are the best ingredients to a successful change management.
Thank you, Bill. And, I think that the agencies that are on the call and listening in on our webinar today, they know that NAC has been here through them, through thick and thin this year, and particularly on the advocacy. I mean, that behavioral adjustment reduction, cut reduction was significant to get that cut in half. And congratulations to the NAC team and to all those who've been basically helping with that. So I think at this point, Bill, this has been a very educational webinar, and we'll be turning it back over to Molly and the team at Axxess to close it out for us. So thank you, everybody, for participating today, and we'll get back to you with any questions you may have.
And thanks, Molly, for all your help pulling this together. It's now back in your hands.
Great. Thank you, Bill and Deborah, for sharing your thoughts and your wisdom with us as we think about preparing even further for the patient-driven groupings model. Don't forget, we will provide everyone with a link to these slides, as well as the URLs for all of the NAC PDGM resources, as well as the Axxess PDGM resources. And we will have a video recording of this presentation available with that information as well. So thank you all for joining us today as we deliver on our mission to empower healthcare organizations and professionals with the world's best technology solutions. Thank you very much. Have a wonderful afternoon.
Thank you for joining our on-demand training today. Axxess is the only home healthcare technology company approved by the American Nurses Credentialing Center to offer continuing education credits and the most recommended home health software on software advice. You can watch more on-demand training videos through our industry-leading help center or at axxess.com, where you'll find tutorials, blogs, white papers, and answers to frequently asked questions. Axxess, empowering care anytime, anywhere.